The topic that we're doing today is sodium disorders. I'm going to be doing both sodium, both hypo and hypernatraemia. So it is going to be a reasonably long topic, but we'll get through it as fast as reasonable. All right, so before we get into the actual disorders, we're going to just talk a little bit about physiology and so on. So we'll talk a bit about sodium homeostasis. So why do we need sodium? It is essentially maintaining water balance. It determines volume and osmolality of the extracellular fluid. It's involved in nerve impulse conduction and muscle contraction. So when we're talking about sodium, we need to talk about water as well. They move together everywhere. So when you're talking about the one by default, the other is involved as well. So in order to calculate the total body water, we use a correction factor, but it's approximately 60% of the total body weight. There are different correction factors based on the patient's age and gender. So for example, in neonates, the correction factor is 0.7, not 0.6, but in general, we can say it's approximately 60%. So this is relevant later on when we're talking about free water deficits and so on. Then of that total body water, 2/3 is intracellular fluid and 1/3 is extracellular fluid. And then of that extracellular fluid, 2/3 is interstitial and 1/3 is intravascular. Okay, hi to all the people that have joined. Just to let you know, we are doing both hypo and hypernatraemia in this talk. All right, so sodium is the primary solute in the extracellular fluid. The majority of sodium in the body is also contained in the extracellular fluid, and the normal concentration is 135 to 145 millimoles per liter. So sodium homeostasis refers to the mechanisms that the body employs to maintain the sodium concentration in this extracellular fluid. All right, so the kidneys are the cornerstone of sodium homeostasis. So if you can remember a little bit of anatomy, the kidneys are made up of millions of nephrons. Each nephron is made up of a renal corpuscle, which is the glomerulus here, and then the Bowman's capsule, which is then connected to this renal tubule. So blood enters the glomerulus here with the afferent arteriole. Then everything apart from red blood cells and protein passes into this Bowman's capsule as the filtrate, and then into the renal tubule. The blood vessels then exit the renal corpuscle as the efferent arteriole, and then splits into the peritubular vessels which surround this nephron. And then ions like sodium are reabsorbed from the renal tubule into these peritubular vessels. All right, so these numbers here in black and blue are referring to the amount of sodium and water that are reabsorbed respectively. So we can see that the majority of sodium and water are reabsorbed from the proximal convoluted tubule, 67%, immediately after being filtered. And then as we get to the distal convoluted tubule and the collecting duct, the percentages are much lower, and this is just where sodium concentration fine-tuning is taking place. So there are a whole lot of mechanisms that regulate sodium and water balance. So we have the afferent mechanisms. So these are receptors throughout the body which provide feedback relating to the body's fluid and osmolality status. So we have cardiac, atrial, and renal baroreceptors, and then osmoreceptors which detect the plasma osmolality. And then we have efferent mechanisms which respond to this information gained by the afferent mechanisms. So the first is renal factors, and specifically the actual glomerular filtration rate. And then we have a few neurohumoral factors, which we will talk about. So these are the factors that are, this first group is the factors influencing reabsorption of sodium. So the first is the renin-angiotensin-aldosterone system, which is activated in response to low blood pressure. So angiotensin 2 acts at the proximal convoluted tubule, where it stimulates the sodium-hydrogen exchanger. And so both sodium and so sodium is reabsorbed in exchange for hydrogen being excreted. And it also causes vasoconstriction of the afferent arteriole, which leads to less filtrate. Then aldosterone acts at the distal convoluted tubule in the collecting duct. It stimulates epithelial sodium channels on principal cells. And we saw towards the end of the renal tubule, this is where sodium fine-tuning occurs. Then we have antidiuretic hormone, which we know is secreted by the posterior pituitary gland, also in response to low blood pressure or to increased serum osmolality. It acts at the ascending leukopenii and the distal convoluted tubule, and it stimulates the sodium potassium chloride co-transporter, so all three of those ions are reabsorbed. And then the sympathetic nervous system acts at the proximal convoluted tubule, and it also causes vasoconstriction of the afferent arteriole, decreasing the blood filtration rate. And then these two are factors that influence sodium excretion. So the first is parathyroid hormone, which is released in response to low calcium or increased phosphate. It acts at the proximal convoluted tubule, and it inhibits the sodium phosphate co-transporter. And then you have peptides like brain natriuretic peptide and atrial natriuretic peptide. So these are released in response to essentially raised blood pressure, act at the distal convoluted tubule, and they inhibit those epithelial sodium channels. They also cause vasodilation of the afferent arteriole and vasoconstriction of the efferent arteriole, thereby increasing the blood filtration. So this diagram is, we won't go through it in detail, but essentially it's just a representation of some of the factors we spoke about. So on the left, figure A is showing how ADH acts on the kidneys and promotes sodium and water absorption, and on the right-hand side is showing the renin-angiotensin-aldosterone system. Okay, and then the last bit of just technicalities and terms. So first is osmolality versus osmolarity. So these terms we know are often used interchangeably. They include the concentration of all solutes in the plasma. Osmolality is the solute concentration per kilogram of solvent, whereas osmolarity is the solute concentration per liter. Osmolality is measured in the lab with the osmometer, so we'll have to get that result from the lab, whereas osmolarity is calculated using this equation. So there are a few different equations for osmolarity. This is the equation that uses the units that we normally get our results in, so millimoles per liter. So it's 2 times the sodium plus the glucose plus the urea. So often we will not have access to the urea results at the time that we need this osmolarity calculation to be done. That's fine. We can estimate the osmolarity using just the sodium and the glucose from our blood gas, because the urea contributes the smallest amount to the osmolarity. So even if we don't have access to that, we can still estimate it. And then the normal ranges are quite similar, around 280 to 290 milliosmoles per kilogram. The osmolar gap is the difference between the osmolality and the osmolarity, and it's usually less than 10 milliosmoles, but there are certain conditions that can cause a raised osmolar gap. So things like ingestion of toxic alcohols, hypoglycemic conditions, and so on. And then the last one is just osmolality versus tonicity. So tonicity is the measure of the osmotic pressure gradient across a membrane. And this is influenced only by solutes that cannot cross a semi-permeable membrane, and these are referred to as effective osmoles. So just to give an example of why we actually care about these terms, so if we think of 2 fluids, normal saline and 5% dextrose water, both of these fluids are isoosmolar, so they have similar osmolarity to plasma. However, normal saline is isotonic because the ions cannot freely cross the semi-permeable membrane, whereas 5% dextrose is hypotonic because the dextrose freely diffuses across the cell membrane, and all that we're left with is the free water. Okay, so there's just that discrepancy between the tonicity and the osmolarity. Okay, so we're going to talk first about hyponatraemia. So this is defined as a sodium concentration in the plasma of less than 135 millimoles per liter. We can classify it as mild, moderate, or severe based on the absolute concentration. It's a common problem in ICU. More than 30% of ICU patients have a sodium concentration below 135. And it's an independent predictor of mortality in these patients. So they have up to 33% higher mortality than in normonatremic patients. And then just very importantly, the speed of onset of the hyponatremia is more important than the actual overall deficit. Right, then a clinical presentation. So majority of patients with a sodium concentration greater than 125 will be asymptomatic. Those that are symptomatic, majority of the symptoms will be neurological, and this is due to the rigid limits placed on the brain by the skull. So the neurological symptoms can range from headache, restlessness, lethargy, depressed reflexes, confusion, seizures, and coma, and then ultimately death. And then the non-neurological symptoms are very non-specific, so things like anorexia, nausea and vomiting, weakness, and muscle cramps. So the clinical presentation is typically related to the level and the rapidity of onset, as we said, and the presence or absence of cerebral edema. So when we are presenting with a patient with hyponatremia, this is our sort of general approach. So we'll start off with the history, as in all patients. Step 2 will be to assess the serum osmolarity. Step 3, assess the volume status. And then 4th step is to assess the urine sodium and osmolality. So we won't usually have access to those results, the urine sodium and osmolality. But as Dr. Betty Santon pointed out the other day in the ED talk, we can sort of estimate these based on, just looking at the urine. We can see if it's concentrated or dilute. We can use a normal urine dipstick and use the specific gravity. And there are some blood gas machines that actually can take urine as a sample, and we can get the sodium returned from that. Our gas machine in our ED, we cannot use urine, but there are machines out there in which you can. So just to know if you are working in a different department. All right, so this flow chart, I'm sure we have all seen some version of this from medical school and from chem path and that. We don't have to remember this, but it's just so that we can go through it and sort of have a logical approach to hyponatremia. All right, so as we said, step 1 was to assess the plasma osmolality. Now, just to note, true hyponatremia is a hypoosmolar state by definition. So these other types of hyponatremia, they are caused by fluid shifts from osmotically active solutes, and they are not true hyponatremias. So we'll just quickly touch on those to get them out of the way. So we'll start with isoosmolar hyponatremia, so a patient with a low plasma sodium but a normal osmolarity. All right, so as I said, this is a pseudo hyponatremia, and essentially it's caused from a changed ratio from other osmotically active particle or substances. So in normal serum, about 93% of the serum is made up of water and the aqueous components dissolved in the water, and 7% from non-aqueous components like lipids and proteins. So normally those lipids and proteins don't affect the tonicity, but in certain conditions like hyperlipidemia or hyperproteinemia, the ratio is artificially changed, and so it causes an apparent decrease in the sodium concentration, but it's not a true hyponatremia. All right, these are rare conditions. We're unlikely to see these often. And then hyperosmolar hyponatremia is also pseudo-hyponatremia. It's referred to as translocational, also from osmotically active particles. In this case, they cause movement of water from the intracellular fluid to the extracellular fluid, and this causes a dilutional hyponatremia. So a common example is in hyperglycemic conditions like DKA or HHS, where the high glucose level in the blood causes or extracts water from the intracellular space into the extracellular space, and then this dilutional hyponatremia. So it's just important that if we do see patients with hyperglycemic conditions and on their gas we see that maybe they have a low sodium, we need to correct the sodium for the hyperglycemia. So the ratio between these is for every 1 millimole per liter increase in serum glucose, there's a corresponding decrease by 0.3 millimoles per liter in the serum sodium concentration. So please don't start replacing sodium in DKAs. We need to first calculate the corrected sodium. All right, and then we'll move on to hypoosmolar. So these are now the true hyponatremias. Okay, so then we said that the third step was to assess the patient's clinical volume status. We'll start with the hypovolemic patients. So look, in these cases, I mean, it's common causes of hypovolemia, and on the hypovolemic side, it's common causes of hypovolemia. So in the hypovolemic patients, we have relatively greater loss of sodium than we have of water. We can have GIT losses or any other extrarenal losses like burns, pancreatitis, or bowel obstruction. Then we have hypovolemic patients with a raised urine sodium. So these are patients can be caused by diuretics, patients with Addison's disease, cerebral salt wasting syndrome. So this is a hypovolemic hyponatraemia in the setting of a CNS disease like TBI or a space-occupying lesion. So the patient is hypovolemic, but they still have concentrated urine. Then we have something called salt wasting nephropathy, so also a hypovolemic hyponatremia, in this case with natriuresis, and it's caused by conditions like congenital adrenal hyperplasia or steroid withdrawal or renal tubular injury and so on. Then the hypovolemic patients, so as I said, these are the common causes that we know of inappropriate water retention, so it can be things like nephrotic syndrome, cirrhosis, heart failure, hypoalbuminemia, and then acute or chronic renal failure. And then the euvolemic patients, so again, we can divide it into reduced urine osmolality or raised urine osmolality. We have things like psychogenic polydipsia. Then we have a condition called reset osmostat. So this is a condition, it's actually considered a subtype of SIADH, but this is a condition where the body's homeostatic mechanisms are aiming for an altered osmolality level. Right, so it can be caused by several conditions like pregnancy, quadriplegia, intracranial hemorrhage, TB, malignancy, a whole host of things, and essentially treating some of the reversible causes should correct that reset osmostat. Then we have something called beer-protomania. So this is a condition in which excessive intake of beer, in particularly, which has a very low solute content, can result in a severe hyponatremia. And then iatrogenic through administration of things like 5% dextrose or inadvertent administration of half normal saline. Then euvolemic patients with raised urine osmolality can be things like SIADH, which we'll touch on, hypothyroidism, glucocorticoid deficiency, and certain drugs. So I just want to speak about SIADH for a second because it's something that is often mentioned, but maybe not well understood, or a lot of hyponatremias are incorrectly attributed to SIADH. So SIADH is a condition in which there's an increase in the ADH secretion by the posterior pituitary gland, which is inappropriate to the current plasma osmolality or fluid status. So these patients have concentrated urine despite having hypotonic blood. So the diagnostic criteria are the patients must have a hypotonic hyponatremia, they have a urine osmolality greater than the plasma osmolality, a urine sodium concentration greater than 20 millimoles. They have normal renal, cardiac, pituitary, adrenal, and thyroid functions. So they don't have another cause to explain the hyponatremia. They are euvolemic, and the condition responds to fluid restriction. So for the causes of SIADH, there is just this acronym MAD-CHOP, which gives the broad categories. So it can result from major surgery like abdominal or thoracic or pituitary surgery, ADH production by tumors, very commonly small cell lung carcinoma, or also blood cancers like leukemia and lymphoma. Certain drugs, specifically antidepressants, anti-epileptics, and psychotropics. Then CNS disorders like TBI, space-occupying lesions, encephalitis, abscesses, and so on. Hormone deficiencies like hypothyroidism and adrenal insufficiency. Other causes are things like Guillain-Barré syndrome, giant cell arteritis, and then pulmonary disorders like pneumonia or TB, or lung abscesses, and so on. All right, then in managing hyponatremia, it's easy, but it's also not so easy. So the first thing is to note that acute severe hyponatremia is a life-threatening condition. So we need to treat it like any other life-threatening condition and resuscitate that patient first. So we start with the A, B, C, D, E's, as we always do. In these patients, if they have if they are neurologically compromised, so these are patients who might be actively seizing, or they can also have things like respiratory arrest from the hyponatraemia, we need to acutely raise their sodium concentration. So we will bolus these patients with, okay, in this case, the example that I've used is 3% hypertonic saline. We can give them 2 moles per kg bolus over 10 minutes, and this should increase the serum sodium concentration by approximately 2 millimoles per liter. We don't have to use 3%. We can also use 5% hypertonic saline. We can also use sodium bicarbonate. Remember, we get 4% and 8%. Right? This can be repeated again if the severe features persist. So it's important to note here that, as we'll see on the next slide, this is greater than the recommended sodium correction rate, but the risks of leaving the hyponatremia untreated and allowing these neurological symptoms to persist outweighs the risks associated with rapidly correcting the hyponatremia. Right, so our first priority is to halt the current neurological symptoms and prevent any further severe neurological consequences. Right. Once the patient has been stabilized, now our goal is to increase the sodium concentration by not more than 12 millimoles per liter in 24 hours. Some literature says 8 millimoles, some says 10, but in general, definitely not more than 12 millimoles per liter in 24 hours. And whatever we have given in resuscitating the patient, let's say I gave 2 boluses and I increased the sodium concentration by 4 millimoles per liter. I now only have 8 millimoles per liter remaining for the rest of that 24 hours. Right. So there are a few different formulas to calculate the sodium deficit and the infusion rate of the fluid that we're giving. However, we have MD Calc. We can make friends with it, we can use it, and it reduces the risk of user error or making mathematical errors. So there are 2 different calculations on MD Calc. The first is for the sodium deficit in hyponatremia. And then after you've used that, you then use it to calculate, then you use the sodium correction rate in hypo or hypernatremia calculator. So in that, it'll ask you for the sodium deficit that you've already calculated. It will ask you which fluid you're using, and it will ask you at what rate you want to correct the sodium. And if you choose a rate that's too high, it will give you a warning. So it's very user-friendly. And as I said, it decreases the risk for user error. And then, as I said, it will ask you which fluid you're using, because obviously we have different sodium concentrations in normal saline versus the different hypertonic salines. All right, then in stable patients, so the treatment is based on volume status. And just to mention here, in patients who are stable and have few or no symptoms, active correction of hyponatremia with hypertonic saline is not indicated, and it's potentially harmful. So we reserve that for patients who are acutely compromised. So in hypovolemic patients, our primary goal is to restore intravascular volume. Once the intravascular volume is restored, the body will stop secreting ADH, our renal function will improve, and the kidneys will get rid of the excess free water that we've given during resuscitation. So normally in these cases, we will use normal saline. Then in hypovolemic patients, at the end of the day, we have to optimize the underlying condition that's causing the hypovolemia and the hyponatremia, whether it's CCF or renal failure or whatever the case may be. So depending on the specific condition, we'll usually fluid restrict and possibly remove excess fluid with things like loop diuretics. And then we can also use things like Vactins. I don't know if these are even available in South Africa, but Vactins are vasopressin receptor antagonists. So they can be used for specific chronic euvolemic conditions. All right, then the complications. So the first one is cerebral edema. So this is the result of fluid shifting into the intracellular space from the vascular space across the osmotic gradient. It results in raised ICP, and as we said earlier, this is from the rigid constraints on the brain by the skull. And patients who are most at risk are those on thiazide diuretics, children, psychiatric patients with polydipsia, and hypoxemic patients. And then the second severe complication is osmotic demyelination syndrome. So this is an irreversible syndrome of neurological symptoms. It is iatrogenic, which is caused by too rapid correction of the sodium concentration. Right? So it's, there are different sub-syndromes, but it's most commonly central pontine demyelinosis, in which the brainstem is affected. And the symptoms can progress from a fluctuating level of consciousness to confusion, eventually to seizures, and culminates in a locked-in state, which again is irreversible. So just to be careful here, a lot of these symptoms are similar to the symptoms of severe hyponatremia. So we need to just be careful and, again, do serial sodium levels to check at which rate we'll be correcting the sodium. Right, and then just because of our specific setting, we must take into consideration some pediatric considerations. So any child receiving IV fluids is at risk of developing hyponatremia. And so giving IV fluids in children should be considered an invasive treatment. So we know that peds gets upset when we, incorrectly or unnecessarily give IV fluids, and that's with good reason. So please, we shouldn't be giving boluses to children who are not shocked. We shouldn't be giving IV fluids to children who can take oral fluids. Children are at higher risk for developing cerebral edema, and this is because they have a higher ratio of brain volume to skull size. The highest risk are those below 16 years old and those with hypoxia. And hyponatremia caused by SIADH is particularly noxious in children with neurological injuries, such as in the case of encephalitis. Right, I do have a case here, but I'm going to skip it. Please feel free to look at it in the PDF that I'll share after the talk, but I'm just going to skip it for now based on time before the talk cuts out. All right, so now we're going to move on to hypernatremia. I promise it's a bit faster and less complicated. So hyponatremia, this is now a condition in which there's relatively excess plasma sodium to the total body water. It can be caused either by a net loss of water or a net gain of sodium. More commonly, it will be caused by losing more water than sodium. It is always a hyperosmolar condition, not like in hyponatremia where we had the pseudo-hyponatremias. It is always hyperosmolar. So this increased plasma osmolality, or the higher sodium concentration in the extracellular space, causes water to move out of the cells into the extracellular space, causing cell volume and cell dehydration. So hypernatremia is less common than hyponatremia because patients are protected against hyponatremia by thirst and the release of antidiuretic hormone. So in alert patients with an intact thirst mechanism and the ability to obtain and drink water, seldom develop hyponatremia in the absence of another medical condition. So hyponatremia is a sodium concentration of greater than 145 millimoles per liter. It can also be classified as mild, moderate, or severe based on the absolute concentration and acute versus chronic. The same as in the case with hyponatremia, the rapidity of onset is more important than the absolute sodium concentration. It has a 4 to 26% prevalence in ICU and a mortality between 28 and 70%, which is a very large range. But I think what we should take from that is even the lower end, 28% mortality, is still very high. Okay, then we have another protective mechanism against severe hypernatremia, and it's called cerebral osmoregulation or cerebral adaptation. So this is a protective mechanism against severe cellular dehydration, and it attempts to maintain brain volume. So in this figure A, on the left is a normal cell with a normal osmolality and a normal sodium concentration of 140 millimoles per liter. The cell above, B, so this is acute hyponatremia, in which there's excess sodium outside of the cell, and this then causes water to be extracted from the cell and causes loss of cell volume and intracellular dehydration. That is what happens in acute severe hyponatremia. Cell C over here, this is chronic hyponatremia, which either can be from a slower development of the hyponatremia, or it can develop from untreated acute hyponatremia. So in this case, The brain adapts by generating and accumulating idiogenic osmoles, which are these little green triangles. So idiogenic osmoles are organic molecules. They're usually things like amino acids or amines. And so the brain generates them and accumulates them to maintain the intracellular osmolality and prevent this water from being extracted and prevents cellular dehydration. So this starts within hours of the development of hypernatraemia, and it's usually fully established by 2 to 3 days. So just to note that chronic hypernatraemia does not mean weeks or months necessarily. This process is established in 2 to 3 days, and it becomes important when we talk about treating hypernatraemia, which we'll get to. So these patients, the clinical presentation, so there's a cute little acronym here, fried and salted. So these are just the general clinical symptoms that the patients can present with. So they can have a low-grade fever, they can be restless or agitated, or in infants they can present with irritability. They can have fluid retention and edema, dry mouth, flushed skin, confusion, low urine output, thirst, raised blood pressure, and decreased energy. So just to note here that the classic signs of dehydration may be masked. So these patients present as fluid overloaded, but in fact they are intracellularly depleted. And then, as with hyponatremia, in cases of acute severe hypernatremia, the symptoms are typically neurological in nature, and it's related to that severe dehydration of brain cells. So patients can present with focal neurological deficits, seizures, and coma. They can also present with thrombosis due to increased blood viscosity, decreased left ventricular contractility, and rhabdomyolysis with renal failure. So our approach is similar to what we went through with hyponatremia. We start with history. These patients are all hyperosmolar. We assess the volume status, and then again we can clinically or with urine dipsticks and so on assess the urine sodium and osmolality. All right, so again we have our flow chart, but it's a bit less convoluted than the hyponatremia one. So we'll look at the volume status. We'll start with the hypovolemias. So the hypovolemic patients, these are usually causes that are related to excess loss of water, and the hypervolemic conditions are usually related to excess salt. So the hypovolemic conditions, we again have urine sodium can be low or high. We have conditions like adipsia and hypodipsia, which can be primary or secondary. So primary adipsia, it's uncommon that we'll see that it's due to damage of the hypothalamic osmoreceptors, but it is common to see secondary adipsia and hypodipsia. So this will be in obtunded patients due to maybe the patient has had a CVA or they're post-operative or they have hypoglycemia. And so these patients are either not able to communicate thirst or they're not able to obtain and drink water themselves. The same goes for critically ill patients, extremes of age, so the very old, and infants. And then, of course, our extrarenal water losses, specifically important for us, will be gastroenteritis, but also things like burns and bowel obstruction and so on. Then it can also be caused by diuretics. Then the euvolemic patients, so again, we can have hypodipsia. The important one here that we'll just touch on afterwards is diabetes insipidus. And then the hypovolemic patients, so as I said, these are usually conditions that result in increased salt relative to the amount of water. So these are things like salt poisoning, which is most commonly iatrogenic. So this will be things like administering sodium bicarbonate during a resus, or inadvertently giving a patient hypertonic saline when you meant to give normal saline. It can be from incorrect preparation of peritoneal dialysis formulas or parenteral feeds, incorrect mixing of formula in formula-fed infants, and then medical conditions like Conn syndrome or Cushing syndrome. This diagram, this picture, is essentially just all the causes again that I've just mentioned, but I think it's just a bit easier to understand. It's just divided the conditions into net sodium gain versus net water loss, but it's all the same conditions that I've just mentioned. So you can go through that at your leisure. So I'll just quickly mention something about diabetes insipidus. So this is a condition in which the body does not respond to antidiuretic hormone. It results in maximally dilute urine with a low urine osmolality, despite patients having a high plasma osmolality. So diabetes insipidus can be either central or nephrogenic. Central diabetes insipidus is a result of a defect in the central release of ADH. So the posterior pituitary gland is not releasing the ADH. So it's caused in general by intracranial causes, a few of which are listed there. And then nephrogenic diabetes insipidus is when the posterior pituitary gland is releasing ADH, but there's a defect in the renal ability to respond to it. And there are a few causes listed there as well. So diabetes insipidus, how do we diagnose it? As I said, it's an inappropriately low urine osmolality. So I just want to say something here. Throughout the talk, I've been talking about low urine osmolality, but what does that actually mean? So our urine osmolality has a very wide range. It can be 100 milliosmoles up to 800 milliosmoles. It depends on the time of day that you're measuring, depends on how much water the patient has had to drink, so it's got a very wide range. But essentially, the urine osmolality should not be lower than the plasma osmolality. Right. So in diabetes insipidus, we'll have an inappropriately low urine osmolality. It will usually be less than 300 milliosmoles, which we know is approximately what the plasma osmolality should be. We can measure the serum ADH levels. This will be low in central insipidus, or it will be high in nephrogenic insipidus because we're not having that negative feedback. Then we have something called the water deprivation test. So the formal way to do this is to fluid restrict the patient until there's a loss of 3% of the body weight, and then assessing whether the whether the urine osmolality rises above the plasma osmolality. So essentially whether the patient has the ability to concentrate the urine when they are fluid deprived. In our setting, so it's not necessarily done so formally. This will obviously be done in an ICU. We're not going to do this in the emergency department, and certainly not in a dehydrated patient. But so, yeah, the patient will be fluid restricted and we'll just assess whether the urine concentrates. Then we can also administer desmopressin, which is a synthetic form of vasopressin, and then again assess whether the urine concentrates or not. So this will distinguish between central and nephrogenic diabetes insipidus. And then the treatment, we won't go into detail here. For central insipidus, we'll give desmopressin. For nephrogenic, we'll give hypertonic fluids and thiazides. Right, so again, the management, our first step is to resuscitate the patient, right? So again, acute severe hyponatraemia is a life-threatening condition. It's a medical emergency. As with any other patient, we'll A, B, C, D, E, and stabilize this patient. And I really want to stress here that in these patients, the majority of them will present volume depleted, and our first priority here is to restore the intravascular volume. Our first priority is not to reduce the sodium level. Our first priority is fluid resuscitate the patient. Right? We do this using isotonic fluids. We do not give large boluses of hypotonic fluids. Right? Ideally, we'd want to use a balanced crystalloid like Ringer's or Balsol or Plasmolite, but you can use normal saline if you don't have anything else. Right? So it is not contraindicated to give normal saline to these patients, even though it has a relatively higher sodium concentration than plasma. Right? Our first goal is to fluid resuscitate. Right? Again, as we said earlier, with the cerebral osmoregulation, in acute severe hyponatremias, these patients have not had time to complete the cerebral adaptation. So they have not yet generated those idiogenic osmoles, and so they're at lower risk for developing cerebral edema. So the risk of not resuscitating these patients is much higher than the risk of them developing cerebral edema. Okay. Then once the patient has been stabilized, we now have to correct the sodium concentration. Again, the goal is to reduce the sodium concentration by not more than 12 millimoles in 24 hours. Again, there do exist calculations to calculate the free water deficit and the free water content of the fluid that we're giving the patient. However, again, these do exist on MD-Calc. So there's a calculation for the free water deficit, and then there's the same calculator for the sodium correction rate, in which you'll provide the patient's details, their age, their sex. You'll provide which fluid you're going to be resuscitating with, you're going to be correcting with, and the rate at which you want to correct. So again, this just reduces the risk for user error, and we should be using these tools that are available to us. Importantly, the oral route is preferred. So in patients who are able to drink, please, we should rather switch to oral or nasogastric fluids instead of IV fluids. And we should be doing serial sodium checks to check the rate at which we are reducing the sodium. Our complications, again, is cerebral edema. The mechanism is the same as what we spoke about earlier with the hyponatraemia, but in this case, it's the result of too rapid correction of the sodium concentration. And this is a particular concern in patients with chronic hyponatremia, in which osmoregulation has had time to complete. The second severe complication is intracerebral hemorrhage. This is the result of the rapid reduction in brain volume from that intracellular dehydration, and which leads to increased risk of vascular rupture. And then our pediatric considerations. So hyponatremia in infants and children is rare outside of other medical conditions, but it has a mortality rate of 15%. So even mild hyponatremia must not be ignored, it must be investigated and managed. Those with the highest mortality are infants with hypertonic dehydration, which are the patients that we will mostly be seeing in the emergency department. And also then those with end-stage liver disease. As I said, these patients are often hypovolemic, so our primary focus is on correction of the volume status. And then again, to change to oral rehydration once tolerated. As I said earlier, intravenous fluids in children is considered an invasive treatment. So as soon as they're able to tolerate oral, we should switch to that. It allows for faster correction and there's lower risk of complications. All right. And then for hyponatremia, I have 2 cases, which you're welcome to go through. I think we have 1 or 2 minutes left before the meeting ends, and then I just have my references at the end here.